Well, good Monday morning, OJA. We are excited to have you guys with us. This morning, we're going to have Brandy and Shell talking to us about DBT that they are implementing at Kojak. And then we're going to follow up with Shell talking to us about harm reduction and the Narcan and fentanyl test strips that will be going home with kids who are leaving facilities. But first, we're going to kind of just roll around and tell you guys what we've all kind of been up to within our areas of OJA. So, Carrie, you want to kick us off?
Sure, I can kick us off. So, Hope Work, we have a lot going on. One of the things that we're really excited about is that we've partnered with District 2 and District 6 to roll out the Hope Scale. And that Hope Scale is an assessment. It's our first assessment on well-being. And so District 2 and District 6 are going to assess both the youth and the parents. So we'll get a look at what is needed when we talk about treating the family as a whole. We're hoping that this assessment gives us some of those data points so we know what to do next. And so youth and families are going to be completing that, and we're going to be learning from what that looks like. Also, we've got classes that we're still doing with the youth on the facility. And so we did that for 5 months. And we create those classes. And so we sit down as a team and we say, okay, what have we taught them and what do we want to work on next? So for instance, one of the first things that we did was show them the TED Talk. And so we used the Hope Scale there. And we've reported this out before, using the Hope Scale, showing them the TED Talk by Dr. Hellman, just giving them 1 hour of Hope classes, and then reassessing them, their Hope score rose 2 points.
Oh, wow.
And so I saw where that was like them going up a letter grade in school. Is that correct?
That's correct. It's predictive of a letter grade increase in school. So then the conversation in 1 hour.
That's huge.
That's huge.
Yeah.
So the conversation then began to go towards how do we sustain this increase and then even grow it.
Yeah.
So we took classes in for 4 months after that. So 5 months total. And then we reassessed. And we were able to maintain that score.
That's
so
awesome.
in 5 months, we didn't lose those 2 points.
That's amazing.
Oh.
Yeah. And Dr. Hellman, he saw that. And what was his reaction?
He was very excited about that data.
Yeah.
So one of the things that we're getting to do now that I'm a Hope ambassador is we're getting to work one-on-one with Dr. Hellman. So I meet with him weekly. And we're able to report out some of the things that we're learning, and he's able to give us direct guidance on our next steps. So next steps for that particular project, we're going to begin to understand. We looked at the different units by score, and there's some variation. And so now we're focused on taking in classes to continue those efforts, bringing in people with lived experience so that we can grow that number potentially, and then beginning to look at our other data and begin to understand why are we having differences per unit. And so that's exciting work that we're looking at.
That's great. That's good stuff.
Yeah. So one of the things down the pike with that is we're going to begin to, Dr. Hellman's team is putting together an assessment so we can begin working with staff. Hope Work is working in tandem with that. As we're investing in employees there, we're also beginning to invest in employees with Hope Work.
So what we're going to hear about DBT and Hope Work, you're saying is they're intermixing?
They're separate curriculums. So DBT is a pathway to well-being, and Hope is a pathway to well-being.
Okay.
So a lot of the concepts cross.
Okay.
So we're walking in tandem with DBT. So what is most exciting is it's not contradicting information.
That is exciting.
We don't have to try to intermingle hope into DBT and vice versa because they're very similar in their concepts.
That is new concept for sure.
Yes.
That is new.
And
Yeah.
exciting for us as an agency.
It's amazing to me how much we have grown, right, as an agency.
Absolutely.
Even in just such a short time.
Right.
Like, it seems like it's been leaps and bounds.
And I think that's how change works. I think at first it seems slow. There's a lot of learning involved. There's a lot of trial and error involved. And there's a lot of buy-in and conversations that have to happen. But it seems like then there's momentum.
Right. Right.
Yeah. So I could talk all day about the homework that we're doing. One of the things that I'll mention before I kick it back to Dottie to tell us about some of the stuff going on in the field is, Hope Work is a governor initiative.
Right.
So we were talking about it, the governor took it on, and so now we're beginning to meet with other heads of the agencies on how can we collaborate on Hope Work. And so those are exciting conversations as we begin to work together as a state for the families that we're serving.
Yeah, it'd be amazing to have everyone on the same page, following those same kind of models.
Yeah, so we have youth, we have the dual custody, so we collaborate with DHS and we're aware of those. And the conversations are some of our youth have very hard situations. And hope may be an easy concept for us to introduce with some of our population, but what about our dual custody youth?
Right.
And so those conversations are happening. How do we implement hope across all levels for all families that we're working with?
Absolutely.
So I'll kick it back to Dottie. Tell us a little bit about what's going on in the field and what's coming for workers.
So one of the most exciting things that I've been blessed to be a part of, along with Bobby and Jenny and Austin, is getting our new worker academy that we are going to be rolling out next month. Can't believe it's already like next month.
I know, it's crazy, right?
This year has flown by. So we've met so many times, I can't even keep track. And when I started ages ago, we had a full 2-week new worker academy that really broke down everything, heavy on policy, just really trying to prepare new workers coming into our agency to know exactly what they were expected to be doing and have the support to do what they need to do. So we are kind of going back to that same 2-week model.
Mm-hmm.
So our first week is going to be kind of like JSU one-on-one. We're going to take them through a case from start to finish. And we're also going to bring in some other people that first week just to kind of really round it out. And then we're going to have them break for a couple of weeks because it's hard when you're in the field. You're already working cases, you're doing intakes, you're meeting with people, to go 2 weeks back to back. So we're going to be having the first week in June and then the last week in June. And we're going to be able to use the training center at Kojak, which is a wonderful facility. And then that last week of June for new worker, we're going to have people from state office coming in. You guys are coming in that week as well to talk about different programs, what's available. We have so many exciting new things. And I tell that to clients that come in to the office even now with between FFT and the hub. Now DBT, I mean, if we get that implemented in the field, I mean, they all go hand in hand together.
Right.
So, and we're going to reincorporate YLSI back into the first 2 weeks. So when workers get done, they're going to be able to go back, knock out their videos, be ready to be a full-blown worker,
Right.
and not have to wait. Like we did last year, we had to have a little bit of a break to get them in to do the YLSI training, which is a core component for our workers to be able to fully work cases.
Yeah, I think we're training YLSI the last 2 days of
Last
new
2
worker.
days
Yeah.
of the second week.
Yeah.
So, I mean, they're going to come in. We're going to bombard them with information, but we're going to be real heavy on policy. We're going to be breaking down why we do what we do, guidelines, timelines, and really just kind of work them through and get them as prepared as we can.
Yeah, so I know you guys have been working really hard on redesigning that and kind of coming back to our roots.
Yeah.
And I don't think the intent was ever to get away from that, but COVID threw everybody for a loop, and we had to adjust because we were still hiring on people and they still needed to know how to do their job.
Yeah.
And so there was this huge adjustment for several years. So talk to us a little bit about, now we're bringing it back. What are some of the innovative ways you guys are kind of designing some of that material?
Well, we've really, fortunately, from what we've been doing on the Monday morning meeting and really kind of go back to reintroducing policy, we're able to utilize some of that same information just to make sure, people really know what we're doing and we're staying compliant and we're doing what we need to do for ACA and everything else.
And why we do it.
Yes, why
Right.
some of those, rules may seem tedious to people at times, but there's a reason why we do what we do and how we do it. So it's just making sure that is reiterated. I don't want to give away all the details for all the,
All the new workers out there.
Because we have some really cool things that some of the others have kind of plugged in. But it's working with so many other people. Hunter from Kojak is going to be helping us some as well.
But you're going to do different styles of learning,
Yes.
not just PowerPoint presentations, that kind of stuff.
I mean, we want to actually help them work through a case.
Yeah.
So, because some people aren't as familiar with JOLTS, we're going to have Jamie also helping us a little bit with the JOLTS aspect so that people can familiarize themselves on where they need to go to find, the information they need.
Well, and I think one of the greatest things about New Worker and coming back together and doing it in person and live is just the networking part of it, because you get to know who you are as an agency and who your coworkers are, right? Like I remember, and we were just talking about this yesterday, I think, where I was with a group of people and we were talking about New Worker and who we went through New Worker with. And I think Jay Giesentanner and Rodney McKnight and I are the only 3 left out of our New Worker Academy, I think, that are still with the agency. But you went through with Randy?
With Randy and Amanda.
Did you go with Amanda Leonhardt?
Yeah.
Yeah.
Amanda was, you get excited when you make those connections that carry on as we kind of go into different roles within the agency.
Right.
And you'd be like, oh, well, I know her because we were in the same New Worker class. I can just reach out and see what we can get done.
Exactly.
So we formed those connections almost 18 years ago, and now here we are.
Absolutely.
Still working together.
Absolutely. So, I mean, you form these bonds with people. So, and now that you're going back to spending 2 weeks together, I mean, that's 2 weeks of you're new, you don't know very many people, and you're kind of out of your comfort zone because you don't have your other coworkers there with you. And then you'll have that bond forever. So it's
much of the state are one worker counties. So they don't necessarily have close connections. They don't have people in the office with them.
right.
And you never know when making a connection with somebody in a different part of the state is going to pay off, whether you have a kid that gets, charges in a different county and you got to work with them to get it connected, or just assisting with resources in that area.
Or you've got a kid in detention and now you know the liaison, and it's easier to pick up the phone and say, hey, can you go get a JOLTS picture? We need this. And have a
Absolutely.
teammate. So.
And I know one of the big things we stressed last year with new workers was this is a relationship business.
Yeah.
It's not just the relationships you build with your kids and families, but it's with all those you work with, whether it be people in the field, people at state office, people at, different group homes or Kojak. Building those connections will carry you a long ways.
Yeah, that's accurate. I know Gallup did a study, and they said that pay is actually not the number one reason why people stay with an organization. It's how they get along with their coworkers. Mm-hmm. And if that is a safe space where they like being, they remain.
And I'm not going to treat somebody's horn here, but I mean, she's been one of the biggest influences on my career, being in the same office for so many years. I mean, she's definitely been one of my biggest mentors, if not the biggest mentor. So,
Thanks, God.
Good job. That kicks it off to Allison. So, Allison, what are you doing across the state?
Well, let's talk about the hub and workforce. So I have been able to present at District 3, 7, 2, and 4. 2 and 4 were combined, showing their data. And I am so excited about the data that it is showing right now. And just not to go over all of the data, but I think the number one data point that I really want to talk about is the number of families that we're able to help financially, in the number of families that are coming back for seconds. That number is less than 10% across the state. So that is a huge number. I mean, that is what I think a lot of people initially thought that the hub was going to be, that welfare system, and that we wanted to make sure that we're not enabling families. We really wanted to be that hand up and not a handout. And we are seeing that it truly is, for the most part, a one-time financial help. And families are getting back on their feet, and they're not coming and having to ask for assistance again. So less than 10%. And that's a lot. I mean, we've got 400 and almost 450 referrals statewide right now. And we just turned 14 months old. 14 months.
Oh my
So I can't believe we're just 14 months old. And not every family do we help financially, right? Not every family is it a financial need. But overall, the average in that help is a little under $1,000, like $800 and something per family if we're averaging it out. So that's big time. I mean,
it's life changing.
It really is. And then the other thing, just financially, I think sometimes what we're seeing is there are some workers that haven't asked for a hub referral to be made on their families because they're not quite sure exactly how the hub can help, right? So let's just talk about that a little bit. And it's not just to be able to pay bills or rent, or their electric's cut off or whatever. We can think outside of that a little bit, where they think of the kid that walks to your office all the time. Could we potentially help buy a bicycle so that kid's not having to walk everywhere he goes or she goes? Is there other things that we may be able to help with that is not conventional, but would really make an impact or a difference in that life? So those are the things that financially maybe we could help with. Also remember, this is not just for custody kids. It's not just for kids on probation. These referrals can be on the first time, the first point of contact, the first time a kid walks into your office for an intake. You can see the need, feel the need with a hub referral. Doesn't mean that it has to be the DA is going to file on them. I had Michael from Lincoln County message me yesterday, I think it was, and he was like, "Hey, my DA's filing, but he's not going to get it done for a couple of more months. But this kid got his bike stolen, and he really is in need of a bike. Do I have to wait until he?" No, go ahead, send it in. They don't have to be on a case. It can be, again, that first point of contact. We don't want kids to have to go deep into the system to be able to get these resources from us. So that's one part of the hub that I really wanted to stress. But the other thing is, if you're just not quite sure, email me. I'll be glad to help answer those questions. Or the OJA RSAT, OJA.OJA.ok.gov, right? That's our email address. You can email that and we will respond to you. Because I know sometimes people put 2 L's in my name and then I don't respond because that's not my email address. But the other thing with the hub that I want to talk about is we have transitioned Clay Cody into more of a reentry type position at the group homes. So he is currently at Cornerstone Lighthouse Problematic Sexual Behavior, Scissortail Plus or Thunder Ridge Plus, whatever we're calling that group home right now, and Scissortail Landing. So he's at those group homes, and he is asking for a hub referral on every kid in those group homes. So he's emailing you if you haven't sent one. And he is going to, if you don't have an original birth certificate, JSU worker, if you don't have an original birth certificate, the parents don't have an original birth certificate that you can get to him, then he's going to help assist you with Sharon Strickland. We've already had a conversation with her, and she doesn't mind mass numbers coming in. And we're going to get original birth certificates on all of the youth there. And he is making arrangements to get every youth in those 5 group homes their state IDs. We have made arrangements with Service Oklahoma, and we have certain days that we take them over and he gets their state IDs. We want every kid to have their state IDs. We're also working to get their Social Security cards. That takes a little bit longer than their state IDs, but we're working to get those as well. We also want to help be involved in grand staffings with him so he can know their reentry plans. And then we want to assist you as the JSU worker with those reentry plans. So if families struggle and need assistance financially, or if the youth needs to transition over to the transitional living homes or whatever, we can connect with Randy, because Randy's part of those transitional living homes. We want to fluidly, easily make that transition back into the community much easier. We also want to be there if parents have trouble coming to the group homes for family therapy sessions. If they need gas cards, we want to be a part of that, because the hub can help with that. Teresa Barnes in Texas County, and I keep mentioning Teresa Barnes because she makes referrals to us, but she, in Texas County, she has a kiddo, and we were able to get a hotel room for her kiddo overnight, for the family to be able to participate in family counseling, because it's a long way from Texas County. So, there's things that we can assist with that we haven't had the ability to help with in the past. So,
Or workers had to do it out of their own pocket.
Correct. So, or the workers had to, drive them down the 6 hours or whatever and stay for the 3-hour family sessions because they had to come from so long. So, here's the thing. If you're coordinating with Clay, he knows what we can do. So then he can say, well, hey, why don't we get them a gas card or whatever, maybe. So we're starting with those, and then we're going to roll out into Welch and People and the other group homes after we get a solid base in these.
Well, and I think people also need to remember Hub can be utilized for 12 months after a case closes.
So exciting work being done. Yeah. It is great when we're able to help families like we're able to do now. All right. That's all from us right now. Next, we're going to be having Brandy and Shell on to talk to us about DBT.
And then we're going to follow up with Shell and the harm reduction and our Narcan and fentanyl strip kits that we're going to be sending home with kiddos.
All right. Stay tuned. All right. Welcome back, OJA. We're here with Brandy and Shell and Dottie, and we're going to talk about DBT and how it came to Kojak and what the future is with that program. So I'll kick it to you, Shell, first. And what is DBT and how did it come to Kojak?
So DBT stands for Dialectical Behavior Therapy. And the reason it came to Kojak is several of us went through a length of stay academy through Georgetown University. And we heard from 2 other states that implemented DBT across their respective secure care centers. And what they had seen, it had reduced pretty dramatically peer-on-peer assaults and also staff peer assaults, overall engagement in the program. And so as we sat there and listened to the outcomes from other states, we said, we got to bring this to Kojak.
Good. And so when did that start? When did it kick off?
Gosh, discussion started probably a year and a half ago. Our first step was to figure out how can we do this. And so we have consultants through Behavioral Tech, which is the DBT training entity. And what they advised was getting all of our clinicians fully trained in DBT before we launched subsequent steps, which would be training the entire facility. So I don't know when we completed DBT clinical training, probably in 2023.
October.
Thank you, Brandy.
And so, Brandy, you already went through that training. And so I wanted to introduce you because maybe if our staff haven't had a kid at Kojak in a while, then maybe they haven't got the pleasure of working with you. So this is Brandy, and she is a behavioral health clinician. And so, Brandy, tell us how it was to go through that process with DBT.
So the training we went through was pretty intensive. It was a week in April of 2023 and then a week in October of 2023. I think 30 hours each week of training online. And then in between the sessions, we had to do a lot of homework assignments as a group. And then we implemented DBT at Kojak, I believe in July of last year was the first session that we started. And part of that was learning and being able to communicate it back to behavioral tech, how we were doing when we followed up in October.
Okay, so it sounds a little bit like FFT, and that there was a outside agency helping walk us through what that looked like.
Yeah, so behavior tech has been great as kind of our guiding principle on what DBT looks like clinically. I think the really unique thing about behavior tech that's different than FFT, for example, is our consultant has helped other secure care facilities implement it, facility-wide. So it's not just that the clinicians are doing DBT. I think what makes this really exciting for us as like the clinical team is we're able to involve every staff member at Kojak. So when the group started, the BHCs ran the groups because we're the only ones that had the training. We then implemented weekly consultation to include the JJSs to expose them to the content and help them feel comfortable in co-facilitating groups with us. Most recently, we've opened it up to RCSs being part of the group. The other piece we've done is starting in January, Brandy's going to have to help me, is our consultant with Behavior Tech leads a 3-hour training the first Wednesday of each month. And then we've kind of rotated through replicating that training, and then all staff goes through that exact training. So everybody gets every principle, every skill in DBT so that they're able to use it with the kids day in, day out.
Brandy, you've been able to lead a couple of those classes, yes?
Yes. So Dan teaches it to us, and then we're able to replicate that and teach it to the staff, whether it's in person or through video recording. They can watch it because we have overnight staff as well. But everyone that works at Kojak, whether they're behind the fence or not, is required to take it so that they can be utilizing all those skills and modeling it for the youth that we serve, and as well as the new staff that are coming in.
One of the things I love about this program is that everybody's getting trained in it. So that Kojak as a whole is learning to operate in this way, and everybody gets to do it. So I believe those are available on LinkedIn. Does that sound correct? Where field staff, if they wanted to learn a little bit more about DBT, they could find it?
There could certainly be way more found for DBT in general through Behavior Tech, the website. When it comes to the trainings that we have, I don't think we've made them accessible outside of Kojak staff. That doesn't mean we cannot. So if that's something that's of interest, we'll just get with Abby and what kind of format we can have those posted. Because that's the whole point of it, is so we have the training, we now own the ability to share it with OJA. So it's us doing the training, it's not behavioral tech. So anybody can access it. They might be intrigued, they might be a little bored because it's a lot of training, but that's what part of what's making it such an intensive rollout at Kojak.
So you guys went through 30 hours break and then 30 hours with a lot of homework. But rolling that out for the whole facility, that looks more like January through October, and breaking those long hours into more bite-sized pieces.
100%.
So that kicked off with staff-wide in January, and here we are coming into May. So how is that going?
I think it's going pretty well. The staff are also supposed to be attending the groups that we have on all the units. And I personally have seen an increase in them at least observing. And the intention there is to help them also learn the skills and use the skills, because DBT can be used by not just adolescents, but also adults. And they also may have things that it could be helpful for in their life. And then they can also reinforce the skills for the residents on the units. So it's not just the 1 hour group or 2 hours a week that they're getting those skills reinforced or practicing. It can be anytime.
And I don't know that I ever said what DBT stands for. And I don't know if any of our viewers get stressed out when people start using letters, but I do. And so tell us, what does DBT stand for?
So it's dialectical behavior therapy.
Dialectical behavior therapy. Are the youth getting DBT training?
Yes, they are. And we have 4 units currently open at Kojak. And all 4 have 2 groups a week. So that looks like one of the groups, which is typically about an hour long, you're learning the new skill for the week. And then the next group, you're turning in the homework where you practice that skill and going over it, reviewing it. How did you use the skill this week? What got in the way of you not being able to use it? So that they're actually applying what they're doing. And then there's also a large component that's called the diary card that they're reviewing every week, where they can track the skills that they're using throughout the week, even if it's not what we talked about that week. And then there's also like looking at rating emotions that they experienced that week. Did something happen on a certain day? And then there's the big part with DBT is with a lot of the clients that it was made to help have suicidal ideation or self-harm behavior. So they can also track that on there and then turn or review it every week during group. And so that we can see how they're doing that week.
Wow. So when you said earlier that the classes were happening and that the staff are supposed to be a part of those classes, the staff's getting it twice, kind of, right? Because they've got their own training and they're there when the youth are getting the information.
Yeah. Yeah. So some of them, because not everyone's there during that, but yeah, there's a lot more exposure if they're on the unit when the groups are happening, which is good.
That's good. So you talked to us a little bit about what the youth are learning while they're out there and how they're using it. So who's running those classes? Is that behavioral health clinicians?
So currently it is behavioral health clinicians, juvenile justice specialists at Kojak, and then a music therapist and a drug and alcohol counselor. The goal is to bring in RCS more. I'm not sure that they've actually started leading it so much as observing it, but they absolutely can. You don't have to be a mental health professional to be able to teach a skill, which is the great part about DBT, is that it's very skills-based.
I think with that, because we're rolling through the curriculum over several months, it's really understandable that if you hadn't gone through the 60 hours that the BHCs had, there's some initial anxiety on, can I do this? Like, this feels like a clinical activity. This doesn't feel like I'm equipped to do it. So part of the rationale in all of that January through October training is RCSs will be exposed. Same with the school, same with maintenance, same with nursing. Everybody is getting exposed to DBT. And so we want them to be comfortable with this skill set so that when they see a kid in the cafeteria, when they see a kid on rec, they're able to remind them how to use certain skills. But that exposure and feeling comfortable is something that we hope will be really increased when they complete all of those months of training.
So have you guys gotten any preliminary feedback from any of the residents or staff so far?
I think one thing I've heard is a lot of appreciation from the principal, how much that the school personnel has heard kids using DBT skills. The other thing I've heard is in ITT that the kids are reporting on how their skill set impacts like their ability to phase up and things that they're learning throughout the program. When I was doing groups, Brandy kicked me out eventually because she was like, I can do it better than you. But the kids would talk about in their review. Like Brandy. I know. In their review of the content and even going through some of the skills, I remember a few kids and it would just make me smile, having a realization that this seemed helpful. Not all of it. I mean, not every component of every modality is going to resonate with every kid. But I remember one of the kids who I thought was going to be one of the harder ones, just saying, I won't use the direct quote because it involves a little bit of cursing, but it was like, this is real. And so that was really neat to see something that we're passionate about resonating with the kids as if this seems applicable to me and might actually be helpful.
Absolutely. I know that some of the times that I've been there, I've heard the youth talk about DBT. And although they didn't say anything specific that I'm remembering, it's integrated into their language. Mm-hmm. So they talk about DBT, they talk about those classes are meaningful, and that they use them in their step work. And so that was very interesting to hear, and exciting to hear, because when you take information there, you really want to connect. That's the whole point, is connecting and strengthening and empowering. And so to hear them make those connections and begin to internalize it and use it is powerful.
I would add to your question, Dottie, that we have an assessment that we do. We haven't analyzed that yet or done it consistently to get the results to see more with that was given through with DBT. But we're in our second round currently and planning to re-administer and see if there's results with that, which will be super helpful to have.
Well, and I know Carrie referenced FFT. It seems like there's some similarities for when kids are discharging. Would them going from this DBT therapy into FFT be beneficial? Because does it follow some of the same philosophies or?
Yeah, I would say that coming from a DBT kind of heavy, which would be what is being done at Kojak, going into an FFT intervention is going to make a lot of sense. One of the things that I would say is a helpful component of that transition is how heavy the FFT is on the family. DBT has a lot that's individualized, so working specifically for that particular youth. What can they do for emotion regulation, coping skills, thinking about long-term, but it's more so related to them and what they can be doing. Moving into then FFT helps that paint a larger impact. Now that we're back in the community with our family, that shift in modality would be helpful. Also, continued DBT could also be recommended. And so if you have somebody coming from Kojak and there's a recommendation that staying in that model, that doesn't mean they didn't complete it or they need something negative related to that recommendation. It could just be continued DBT is helpful. So just in case that's seen.
For kids that are coming out of Kojak back into their communities, are there any DBT certified therapists or, HCMs in the community that would be able to provide that service?
So the answer is yes. What I wish the answer could be was like a resounding yes. So DBT, similar to other evidence-based interventions, not everybody is widely trained in that model. And actually being certified in DBT is a pretty lengthy process for people to go through. So it could be that within different areas of Oklahoma, DBT certified clinicians might not be accessible in the community. What you can find, though, more readily is people that have been trained and exposed to the principles of DBT. So I wish we had more across the state, but we don't have as many as we do FFT providers, for example. But we can help find people that have been trained and have an awareness of the skills that are encompassed in DBT.
So I think it could be helpful for everybody to kind of hear about maybe what is one or two concepts that youth are learning and staff in DBT, and kind of how does that play out? How does that concept play out over their learning?
So there's actually 4 domains that they learn. It's mindfulness is the first thing that we start with. And then distress tolerance, emotion regulation, and interpersonal effectiveness skills. So within mindfulness, they're learning about, how to do mindfulness in many different ways. And then within that, we talk about that there's 3 states of mind, which is your emotion mind, your reason mind, which is logic, like very facts-based, and then wise mind, which is a little bit of both. And no one sits in wise mind all the time, especially teenagers with underdeveloped brains. Right. So learning how to get there through using mindfulness. And then in that, they learn the what skills. So observing, describing, and participating is how we do mindfulness. We observe what's around us, be able to put words to it, than fully participate, because that's what mindfulness is for, is to be fully present in the moment. Because I think a lot of things are missed when we're not present. And then distress tolerance. We want to learn how to soothe, cope with difficult situations. The skills are distraction, self-soothing, improve the moment, and then looking at the pros and cons, which is, what is, if I respond in a place from like anger, what's the pro of that? Yeah, I'm going to feel better briefly, but what's the con? Is that going to make me feel better long term? Probably not. How does that affect me over time? Emotion regulation. This is a lot more with coping skills, reducing that vulnerability to emotion mind, increasing, like collecting like positive events that happen and increasing your experience of those. And then interpersonal effectiveness has a lot of really good skills that I think, in my experience, my kids like the most, especially because one of them is learning how to get what you want in an effective way. And then within those skills, it's teaching them, like, if you don't care about the relationship, you could use this skill. If you do care about it, use it this way. And if you want to keep respect for yourself, use this skill. So there's 3 different ones. And I think a lot of them like that, especially we deal with a lot of difficult people, and then being in their position where they have less power than everyone else around them and less control, being able, how do I get what I want in an appropriate and effective way that's not hurting me or other people? So those are the basic domains that they learn, as well as the stuff.
Okay, so for our audience, just a reminder that we had Brandy on last week where she presented DBT more fully for the entire hour. So if you heard something today and you didn't catch that and you had more questions, go back and watch that recording to learn more about DBT fully. All right, you guys. So that is our time segment for today. Thank you so much for coming on and talking with everybody about DBT.
Thank you for having us.
Thanks.
It was so nice to have them come on. I think one of the big takeaways for me is it's exciting to see how the unit as a whole is coming together for one cause, and that's DBT.
Yeah, and I was off camera for that, but what I got to hear about DBT, for me, it really is nice to start trying to grasp what's going on at Kojak. And for a field staff, I think that would be super important to be able to be the voice on the outside of the treatment that our kids are receiving on the inside, because a lot of times we are that person whenever the DA or the judge has those questions about what's the actual treatment that they are receiving. So to be able to hear Brandy present previously on the Monday morning meeting about what DBT is actually, the actual model of it, and then to be able to hear this conversation and to know that it's not just a group that they're attending, but it's skills that they're building, and not just the kids, but the entire staff there at Kojak, down to the maintenance and the cooks in the cafeteria. I mean, that to me is something that is amazing, that it's everybody is in it together.
Well, and they're teaching skills kids can use for the rest of their life.
Right. Well, and not just the kids, but I heard Brandy say that it's something that the staff can use too. So it's true life skills that everybody has a takeaway from.
It's empowering everybody as a whole.
Absolutely. Yeah,
I love that.
I do too.
Yep. So next we'll have Shell coming back on to talk to us about Narcan and the testing strips and what that'll look like rolling it out.
Now, harm reduction, it's a huge thing, I feel like, right now with the epidemic with fentanyl that we have going on right now. So I'm interested to talk to Shell about that.
Me too.
Welcome back. We are here with Shell, and we are going to talk a little bit about the Narcan kits and the fentanyl strips that we are planning on sending home with our youth that are reentering from the group homes and the institutions. So, Shell, can you tell us when we are going to see those kits start rolling out with our kiddos?
Yeah, so all of the transitional living programs, the specialized community homes, Level E group homes, and Kojak all have been given some initial sets of the Narcan and the fentanyl testing strips. Those initial sets were given for any emergent situations that occurred for any youth while in those locations. It was probably about a month ago that we submitted a formal order to DMH for every one of those programs to have a lot of Narcan and testing strips to be given to each resident as they're discharged from the program. So I would say DMH said turnaround time should be within, I think it was an 8-week window based on how many supplies they had access to. So I would say within the next month, if not 2, just to be a little cautious that youth transitioning from all those programs will have access to those supplies.
So when you say emergent kits, that's for them to use on site.
Yeah, if anything happened to a young person while they were at one of those programs involving a concern for fentanyl use, misuse, overdose, that's what those kits were for. But the goal, as you said, was to make sure every kid leaving those programs was given a kit as they transitioned back to the community.
Right. And those are prevention type kits, and the fentanyl strips, we see the billboards of and they say something like expect fentanyl, use it, test it, use a test strip or whatever. And so we as an agency have partnered with DMH and said we want our kiddos to go out and have Narcan on hand and a fentanyl test strip. Not that we are saying we expect our kids to go back out and use.
Right.
That is not our intent.
Correct.
But our intent is to have that on hand in case.
Correct.
Right.
Yeah, it could be that a loved one that this young person is around, or a friend that they're back with, or they're back in the school setting, or at work, whatever it might be. We want to equip young people for the life-sustaining efforts that are needed should a fentanyl overdose occur. So this is not a permission of, we now expect you to go use fentanyl. Fentanyl is a huge epidemic right now. So if you have a crisis that you're involved in, we want you to have the supplies that you need to help somebody save their life.
Right. So are they being trained on how to use the Narcan like we were?
Yeah. So each group home had some initial, and each placement, I should say, had initial training with DMH and exposure to the OK, I'm Ready that shows how to utilize the Narcan and the fentanyl testing strips. What then is to be completed before a young person transitions from the program is continued education on those same practices. DMH is also working with us with some of their peer recovery specialists to do psychoeducation with the kids in all of those programs. Kojak has it actively now with DMH. We've asked them to expand for all of our young people in placements, including SCHs and TLPs. So they're working to be really thoughtful about who they want to go into these programs to give the psychoeducation. But yes, they'll get training on how to utilize those materials and also have exposure to the prevalence of fentanyl and what to do if they are suspecting someone is struggling with substance use, themselves included, how to make those connections. So we're trying to be really thoughtful to make sure they have an awareness of what's out there and what to do if a crisis presents itself to them.
So then let's transition over to our parents of the youth, and how can we as JSU workers prepare our parents in the knowledge of our kids are going to come out of group homes or institutions or TLP, wherever they're coming out of with these kids. Because I think some parents may look at this as we're giving them permission. Mm-hmm. So how do we, as JSU workers, talk to our parents and educate them on the whys of this kit?
Yeah, I think one thing that sounds so simplistic is just a conversation about how wildly accessible fentanyl is right now. Not just within Oklahoma, but across the U.S. This does not have to be something that's like an intensive conversation, but a lot of people do not know that fentanyl is in things like marijuana, right? It's in things like what appears to be a prescription pill. So one of DMH's biggest pushes, and I think I've now become someone pushing it as well, is just an awareness. So it's not a scare tactic or, something to be, I don't know, too frightened about how to approach that conversation. This is just a factual, fentanyl is out there. And so one of the ways that OJA is trying to ensure that lives are saved is giving kids connections and families connections
Right.
to the Narcan and the testing strips.
Right. And so if our families want to know more about it, you had mentioned the website earlier.
Yes. OKI'mready.org is something that DMH has put together specific to fentanyl. So it has facts about the prevalence. It has information on what an overdose might look like. It has those tutorials on how to utilize the Narcan and the testing strips. And I think one of the most impressive pieces of it is also what connections can be made should someone be suffering or concerned with their own substance use or misuse, how to be connected to resources in that. It's a really impressive website that I would direct anybody to that wants to learn more about what's happening.
And so on that website, it's not only the things that you talked about, but families can go on and they can watch a video on how to be trained to use Narcan.
They can.
And then there's also a place that they can order Narcan themselves, correct? Not just families, but anybody can order Narcan for themselves if they don't want to go into a site and pick up Narcan.
You can. And there's also vending machines across the state where you can have free, immediate access to Narcan and fentanyl testing strips. If there's a question about what the vending machine requires, it just requires the zip code. So there's not any identifying information that you have to give. It's just the zip code. The reason for the zip code is DMH needs that information to show where these kits are being used for them to be able to access more. But yes, you can access Narcan directly from okimready.org. You can also see on that website a map where all of the vending machines are across the state.
So with a family, if they are struggling with the kids coming home with their youth, and I would have this conversation as a JSU worker before the youth came out, right? I mean, once we know that those are rolling out, this is a conversation I would have with my families, not the day the kid showed up and then they may have an issue with it, because we don't know if they're going to have an issue with it or not. We hope that most won't, but you just never know. But I would have that conversation. And then if they had worries or concerns about Narcan, because Narcan you used to have to have a prescription to get it. And now you don't. But this website, I would use this as my resource and then pull up the video while the family was in my office. And we would watch that training video together, so that it would show, especially the Good Samaritan, law, and go over that to where if their child uses that to help a friend, and it also show that Narcan, if used and not needed, is not harmful.
Right.
So if their kid can't use it to get high, or, whatever those myths or fears that families have, I would use that video that's very well put together to help subside some of the fears that the families may have. Video that's very well put together to help subside some of the fears that the families may have. And then with the fentanyl testing strips, I would use those as like what you said, fentanyl could be in anything. I have a teenage niece that I have even cautioned her about taking candy, because it can literally be in anything. So it doesn't even necessarily have to be a drug. But like you had said, with marijuana or anything. It's not that we're accusing their kids of using fentanyl, but to always be cautious about any of it. And that's exactly the way that I would phrase it to them, is we want everybody to be safe.
I agree completely. I think terms I keep hearing that I think are appropriate across the spectrum if there's concerns is this is focused on harm reduction. So you don't ever want to find yourself in a situation where someone seems to be overdosing or something that's very significant medically seems to be occurring right in front of your eyes and then be absolutely powerless. So having the information, the education, and the access to actually what can save that person's life is the focus of this partnership with DNH.
So last thing I think that I have, and Dottie, I know that you said you had something that you wanted to ask, but
Yeah, I think this conversation about overdose and Narcan can be had. I've had it with parents at intake.
Mhm.
Like, even if you have prescription pain pills in your home and you have small children or elderly parents that you're afraid they may take too much, have Narcan. So it can be there just to assist in those type of overdoses, not even just fentanyl. So, because I know a lot of people, you get those pain pills written when you have a major surgery, may not take all of them. Most people don't drop them at their designated drop areas or sheriff's offices or wherever. So just having that as a precautionary, and like Allie said, you can use it. If it's not that, it doesn't harm, which is amazing.
yes. So for me, if a youth has the kit and they come out and then they use their kit, and I know at our Monday morning meeting where Jason came on, they showed us the form for us as workers to use if we use our Narcan. But do we use that if the kid uses their Narcan, or how do we report are we responsible for reporting if our kid uses their Narcan kit?
So good question. The initial reporting from when the kid is given the Narcan, when they're leaving a program, that's done by the program director. So, for example, if they're leaving Mustang, the program director at Mustang is who documents that specific child was given that supply. If a young person in the community uses that kit, that's not something that JSU has to then report that use has happened. If you want to get that family more, then yes, you would have to do the form that's being set up and that will be distributed across the field for that reporting purpose. So you don't have to do it if a kid comes to you and says, hey, I use the Narcan, there's no need. If you want to give them more, then yes, you'll have to document that more is needed for that particular kid. I should say again, you don't have to put anything on that form other than the zip code. So you're not having to say, Shell Millington used this Narcan in this testing strip and now she needs more. It's just the zip code.
Okay. And then, but if the family or the youth used their Narcan and then they went to the website and they ordered their own Narcan, we're not having to report.
Correct.
Okay. And then for us, if we, as JSU, used our Narcan and we needed it, we're going to use that form and then we're going to get more Narcan. Or if our Narcan expires, and which we hope is the case more often than having to use it. But if our Narcan expires, then we're going to turn that form in and we're going to be able to get more Narcan.
Yes.
That's the goal here.
Yes.
Okay.
And you talked a little bit, Allison, about Narcan expiring. And so I want to remind viewers that we had a presenter on last month, which would be April, that talked to us about Narcan.
Yes.
And so you can go back and review that video. She even reminded us how to administer Narcan, which I think is helpful if it's been a year since we've gone through the last training to review that. But she said that even if it is expired, if that's all you have, please use it.
Yes. Yeah. And I think it's interesting too that we're seeing sometimes with Narcan and fentanyl, it may take more than one shot of Narcan up the nose to revive somebody. So don't give up, and I think that's also an important factor. Is we just need to remember, just keep using Narcan until help gets there.
Yeah, and on that okayimready.org, there is a section that shows you what to look for if the Narcan is or is not yet working. And so thoughtfulness on how to be positioning the person that you're administering the Narcan to. One thing that I just want to reiterate and try to say strongly is, yes, if this presents itself and you see someone that you believe you need to administer Narcan to, please try to remember the first step is call 911.
Right.
So call 911, report what you think is happening. You can be saying it on speakerphone as you're administering the Narcan, because like you're mentioning, it might take repeated doses. But we also want emergency staff coming to where you are so that they can be able to take over and do whatever they can do that are different than what I would be doing as a non-medical professional.
Yeah, absolutely. And, I also want to just stress that this is real life for some of our kids. And, I think I've shared this before, but one of my last kids on my caseload before I didn't have a caseload anymore, he asked me to help him get Narcan because he got into a situation where one of his friends, he walked in and he said, he was great. And he said, I guarantee you it was fentanyl. And he didn't have anything. And so he asked me if I could help him get Narcan. And so I went on the website and I helped him get Narcan sent to him. And he wore a little fanny pack and he carried that Narcan in his fanny pack because he didn't want to not feel empowered to be able to help a friend in need again. And so this is, again, it's real life for our kids, some of our kids that live in these situations. And I think if we can help empower them and give them this tool, they're the ones that are in the situations we as adults may not always be there. And so if we can empower them to help save a life. And whenever we got it, I was going to do a little training with him. And so I went to open it and show him, and he was like, yeah, I've already watched a YouTube video on it. I mean, he was that serious on, he was prepared. He really, truly wanted to know. And so whenever I pulled it out, he was like, yep, that's exactly the one I've watched the video on. He was ready to go because it truly scared him for his friend.
That's a very powerful story, was I think one of the huge motivators of why we're doing this. To feel powerless in a moment like that is such an enormous burden. And so we're trying to take a step back so it's not that moment thinking about what could I have done, what I wish I could be doing. You're being preventative in terms of an awareness on what you can do. And then you now have the ability to know what I'm doing can be effective.
Yeah. And he also was a little paranoid that he might be in trouble for having it on him. Mm-hmm. And I did have to reassure him that it's not illegal for him to have Narcan. It's not a prescription drug, that it is, anybody can have it. So just reiterating that to him as well, that it is safe for him to carry in his fanny pack at all times. He was good to go.
Yeah. So. Yeah. And it's not paraphernalia, so it is.
It's good.
It's good.
It's good.
We can reassure him of that. Until we hear a lot of feedback, a lot of thoughts on harm reduction, but until it affects your life or the kids on your caseload, and you don't know when that's going to be, that's when it hits home. That, boy, I'm very glad that people are investing in harm reduction because I don't want anybody's decision to cost them their life.
Absolutely. Absolutely. All right. Well, Michelle, thank you so much for joining us to talk about Narcan and these kids that are coming home with our kids. If anybody has questions, I say please reach out and let's, if you feel uncomfortable about talking to your families about this, we would love to help you bridge that gap with your families and get you to a point where you're not uncomfortable about having these conversations.
Yes. Thanks for having me.
Thanks.
Welcome back. Didn't Michelle do such a great job talking about harm reduction?
She did.
She did. So, again, just to recap a little bit on that, please go to the website if you have any questions or you need a Narcan kit, or hit up a vending machine because those are popping up everywhere. And you can just put your zip code in to get free kits out of that. Also, we won't be here next week. It is a holiday.
Yes.
So we will see you guys back in 2 weeks.
2 weeks.
Everybody enjoy your day off.
Thank you guys. Have a great week.